Neurology quiz number 122. Describe the pathogenesis, clinical features, and treatment of botulism. Botulism is a rare but life-threatening neuroparalytic disorder caused by botulinum neurotoxin. Botulinum neurotoxin is produced by Clostridium botulinum and related species. Clostridium botulinum is an anaerobic gram-positive spore-forming bacillus. Spores are ubiquitous in soil and marine sediments. They are resistant to heat, survive boiling, and germinate in anaerobic, low-acid, nutrient-rich environments such as home-canned foods. Clostridium botulinum produces 7 botulinum neurotoxin serotypes A to G, with types A, B, E, and F most relevant in humans. Pathophysiology: botulinum toxin prevents acetylcholine release at presynaptic nerve terminals. Normally, the release of acetylcholine at the neuromuscular junction is mediated by the assembly of a synaptic fusion complex at the nerve terminal. The synaptic fusion complex is a set of snare proteins which include synaptobrevin, SNAP25, and syntaxin. The complex allows the membrane of the synaptic vesicle containing acetylcholine to fuse with the nerve cell membrane. After membrane fusion, acetylcholine is released into the synaptic cleft and then bound by receptors on the muscle cell membrane. Botulinum toxin binds to the neuronal cell membrane and enters the nerve cell by endocytosis. The light chain of the botulinum toxin cleaves specific sites on the snare proteins, preventing assembly of the synaptic fusion complex. This blocks acetylcholine release. Toxin types B, D, F, and G cleave synaptobrevin. Types A, C, and E cleave SNAP25, and type C cleaves syntaxin. Preventing presynaptic acetylcholine release causes impaired neuromuscular junction and autonomic transmission. Botulinum toxin does not cross the blood-brain barrier. Recovery requires sprouting of new nerve terminals, which can take weeks to months. Botulinum toxin is the most potent known toxin. The lethal dose is 0.0003 micrograms per kilogram in mice. 1 gram could kill 1.5 million people. Epidemiology: routes. Foodborne: this is ingestion of preformed toxin. It is common with home canned foods, fish, fermented meats, and seafoods, and fermented tofu. Wound botulism: here spore germination occurs in necrotic tissue, and this is often linked to black tar heroin use. Black tar is a dark-colored impure form of heroin which is injected subcutaneously, also known as skin popping. Infant botulism: infants have immature gut flora and low pH, which allows Clostridium botulinum spores, usually ingested in honey, to germinate and produce botulinum toxin in situ in the intestine. Iatrogenic is related to overdose of therapeutic botulinum toxin injections, and inhalational, which is rare and is a potential bioterrorism route. Outbreaks are reported worldwide. The US averages 160 cases annually, with infant botulism the most common. Mortality has dropped from 60 to 70% in the pre-1950s to 3% overall due to ICU care and antitoxin availability. Clinical features: mental status is normal. Acute bilateral cranial neuropathies occur with blurred vision, diplopia, ptosis, dysarthria, dysphagia, and facial weakness. There is symmetrical descending weakness, which moves from proximal to distal and trunk and upper extremities to lower extremities. Respiratory failure from diaphragmatic paralysis is common. Autonomic features include dry mouth and fixed and dilated pupils. However, these are not reliably present and occur in less than 50%. GI dysmotility, as well as blood pressure and heart rate lability. Patients are usually afebrile except in the wound form associated with wound infection. Infants present with constipation, weak cry, and hypotonia. Diagnosis. Clinical suspicion is critical and therapy should not await lab confirmation. Suspect botulism in any patient with acute cranial neuropathies and descending weakness without fever or sensory loss. Toxin detection. Toxin detection confirms diagnosis. Botulinum toxin in serum, stool, or suspected food/wound via ELISA or PCR. Test serum and stool to improve sensitivity. In infant botulism, stool is preferred. Because testing may be slow or insensitive, start antitoxin empirically when the condition is suspected. EMG and nerve conduction studies. The nerve conduction studies reflect presynaptic neuromuscular junction disorder and findings are similar to LEMS. There are reduced CMAP amplitudes, while sensory studies and nerve conduction velocities are normal. Repetitive nerve stimulation, post-exercise or high-frequency stimulation shows an incremental response. However, only 60% of adults have significant post-exercise facilitation. The magnitude is typically 30 to 100%. Versus more than 100% in LEMS. Needle EMG may be normal or show short duration, low amplitude motor unit potentials. Single fiber EMG shows increased jitter. This slide shows rapid repetitive stimulation in the left APB of a patient with infant botulism with 38% increment at 20 Hz and 94% increment at 50 Hz. Management. Number one, supportive care. All suspected cases should be hospitalized. Patients are admitted to the ICU and monitored for respiratory/autonomic instability. Early intubation as needed. Antitoxin therapy. Immediate notification should occur to the State Health Department to obtain antitoxin and coordinate with CDC. Antitoxin is the mainstay of treatment. Heptavalent equine antitoxin is given to patients more than 1 year old. Antitoxin neutralizes circulating toxin but cannot reverse established paralysis. Timing is crucial. Greatest benefit occurs when given early, and the goal should be within 24 hours of presentation and ideally within 3 days of admission. Antitoxin treatment shortens ventilation duration and hospital stay. Infants less than 1 year are given human botulism immune globulin IV for types A and B, and this is generally well tolerated. This figure shows a 42-year-old male with history of subcutaneous heroin use who developed acute onset of cranial nerve palsies and respiratory failure. The figure shows evidence of bilateral ptosis and multiple abscesses in the skin on the legs. He received empirical botulinum toxin treatment and abscesses were treated with antibiotics and debridement. Subsequently, botulinum toxin was detected in his serum and Clostridium botulinum was cultured from the abscess. Complete neurological recovery took several months. Prognosis. Mortality is less than 1% in infants and 3 to 5% overall. This is usually from respiratory failure. Recovery is slow and can take months to years. Some patients develop chronic fatigue, weakness, and residual deficits. If respiratory failure is unrecognized, hypoxic brain injury may occur. Prevention and education. Proper food handling and canning. Food should be heated at more than 121 degrees centigrade for 20 minutes at pressure. Boil home canned foods for more than 5 minutes before consumption. No honey for infants less than 12 months. This figure shows various methods for prevention of botulism.